You are listening to the Horse Radio Network, part of the Equine Network family.
Hello and welcome to the Disease Du Jour podcast. I'm your host, Carly Sisson, and in this episode, I spoke with Dr. Maureen Kelleher about diagnostic anesthesia. The Disease Du Jour podcast was brought to you by Merck Animal Health. Dr. Kelleher achieved her doctorate in veterinary medicine from the University of California at Davis. She then undertook an internship at Pioneer Equine Hospital in Oakdale and a residency in equine surgery. She gained several years of valuable experience in equine private practice in California, specializing in equine sports medicine and lameness, advanced diagnostic imaging, and acupuncture. In 2010, she obtained certification as a veterinary acupuncturist, and she gained diplomate status with the American College of Veterinary Surgeons in 2013. Dr. Kelleher relocated to the Marion DuPont Scott Equine Medical Center in Leesburg, Virginia. Her primary focus is evaluating and treating performance-limiting issues in sport horses through non-surgical methods. She collaborates closely with the center's therapeutic farrier team, as well as its medicine and surgery teams, utilizing cutting-edge diagnostic imaging capabilities to deliver exceptional care to equine patients. Thank you, Dr. Kelleher, for joining us today.
No problem. I'm happy to be here.
So can you get us started by explaining what types of lameness exams you might reach for local anesthesia and what types of lameness exams it would be less useful?
So for me, I use diagnostic anesthesia quite a bit. Probably about 98% of lameness cases. Our exceptions are going to be sort of the extremes. So either a very subtle lameness that's very intermittent, or that we would have a difficult time determining whether the horse got better after we block them. And then the other extreme is, if I'm suspicious of a fracture, especially like a distal limb fracture, then I'm probably going to maybe do some other diagnostic imaging to rule out a fracture before I would do diagnostic anesthesia. But pretty much everything in the middle would be totally game for diagnostic anesthesia.
What types of drugs are available for diagnostic anesthesia? And do you have a preference, or are there different applications for different types of drugs?
Yeah, so we do have three main options for anesthesia: lidocaine, mepivacaine, and bupivacaine. And the most common one is mepivacaine, and it's probably better known by its brand name, which is carbocaine. I reach mostly for mepivacaine because it has a relatively short onset of action, and it's probably really the most efficacious. There has actually been one study, at least one that I can think of, that lidocaine was pretty variable with its ability to completely desensitize a foot. I think they were doing a palmar digital nerve block and not all of the feet blocked with lidocaine. So since I don't really want to question whether my block is working or not, I usually tend to steer away from lidocaine, at least for diagnostic purposes. And then the other option is bupivacaine, and that has a longer time for onset of activity and then also a longer duration of activity. So it's not very practical for diagnostic purposes, and I tend to use that more for like pain control or something like that. So really, when it comes to lameness exams, the winner is going to be mepivacaine.
Yeah, that's some great insight. And how do you decide when you're blocking between perineural and intra-articular anesthesia?
So if I'm seeing a horse or a horse is being seen for a particular lameness for the very first time, I usually am going to go with perineural anesthesia, mostly because it's quicker, it's simpler, and I can get a good reasonable estimation of the localization of the lameness. But if I'm doing like a follow-up lameness exam, or I really want to narrow down and solidify my localization, then, either on another day or the next week or the next time I see the horse, then I would move to intra-articular anesthesia to really get more precise localization.
Today's Disease Du Jour podcast is brought to you by Merck Animal Health. Merck Animal Health believes that if we all do right by the horse, we'll never do wrong. That's why they're driven by an unconditional commitment to the horse and to the veterinarians and communities who support them. From infectious disease tracking through the Equine Respiratory Biosurveillance Program, to building a sustainable profession through the Veterinary Wellbeing Study, to creating equine health products with the highest level of safety and efficacy, Merck Animal Health is unconditional. It's just who they are. Learn more at merckanimalhealthusa.com. So, at what point during the lameness exam do you find that local anesthesia is most useful? And then what do you want to watch the horse do while it's blocked?
So I usually wait for the anesthesia until I've seen the horse go in as many circumstances as feasible. So straight line, lunging, etc. And I usually also try to get my flexions done before I do any blocks, because if they're pretty positive to a block, then I may want to repeat that flexion to see if they're better after the block. And then always, if I have the option to have the horse ridden to get any information about how the horse changes or the lameness changes with the rider up, I'll certainly do that. And then after I block the horse, I usually watch them go in whichever situations the lameness was most severe in. So if the horse happened to be more lame with the rider riding the horse, then I certainly would get the rider back up there, look at the horse again. And that gives me also the feedback from the rider on like how much do they feel like the horse changed. So it's not just my eye determining how much the horse is better, but also the rider is giving me some feedback too. But yeah, for the most part, wherever I see the lameness the most, I want to repeat that afterwards. And then, like I said, if the horse was really sensitive to any of my joint flexions, then I'm going to repeat that to see how the block changed the flexion as well.
So can you walk us through the process of, for example, blocking up a leg? What order would you administer the anesthesia, and sort of how do you manage the timing of all of the blocks for maximum efficacy?
First, I'll freely admit that I've been burned by trying to jump up the leg and start, higher or where I think the lameness is. And because I've learned the hard way, I always start as low as possible on the leg and then work my way upward. And since I want to have the most precise localization I can, I try to start as low as possible and then work up the leg in as small as increments as feasible. And certainly I understand that that is sometimes hard to do because of time and patient constraints. Some horses are not going to tolerate all that blocking. So at the very minimum, I'm going to try and break the leg up into reasonable sections for blocking and then subsequent imaging. So like a good example would be if I'm working on a hind leg and I'm worried that the horse is just going to have a very limited tolerance for all these blocks, I'll start with a low 4-point block. And that way, if the horse blocks to that low 4-point, I know I've at least narrowed the lameness down to like the mid-distal limb, and I can rule out all the rest of the upper limb. But then if the horse is still lame, then I know I can safely move up the leg, and I've already ruled out the foot, the pastern, and the fetlock with one block. And I know some people, and this is where I've been burned in the past, and I don't do this anymore, but if they have a horse that they're suspicious has a proximal suspensory, they'll start right away with a deep branch of the lateral plantar nerve block. And then, of course, if the horse gets better, they'll go right to investigating a suspensory injury. However, I've had some cases where that's the first block I've done, and it has the potential to block out the entire lateral side of the limb all the way down to the heel bulb. And then the horse didn't have proximal suspensory disease, but I've had at least one case where the horse has had a lateral suspensory branch injury, and I've had at least one case where the horse has had a lateral collateral ligament of the coffin joint injury, and those were missed right away because I interpreted the response as it had to have been, proximal suspensory, and it wasn't. So I'm usually pretty careful to make sure that I work up the limb in a little bit of an organized fashion and not jump ahead just so I don't miss an injury.
So how long does local anesthesia last and how quickly does it migrate? I imagine this can complicate the lameness exam quite a bit if you have to block multiple parts of the horse and it's migrating in between blocks while you're performing flexions and lameness exams and whatnot. So if you could walk us through that.
That definitely does interfere with how we interpret things in the lameness exam, especially, mostly we're talking about the perineural anesthesia. For the mepivacaine, it lasts about 2 hours in most horses. Lidocaine's a little bit shorter, maybe 45 minutes, and bupivacaine is going to last like up to 6 hours. So again, those two are a little less practical. The anesthesia can migrate pretty quickly. So in the sort of 5 to 10 minutes that we wait for a block to take effect before we go look at the horse again, it certainly can migrate proximal to your intended region of localization. So certainly, given that, we have to be a little bit cautious on how we interpret things. And I certainly always try to check my blocks, and I'm going to check my blocks even higher than where it should normally desensitize. So first I'm going to check to make sure that the block is working, meaning if I do like a palmar digital nerve block, that the heel bulbs are desensitized. But also in that situation, I'm going to check to make sure that the dorsal aspect of my coffin joint, my pastern joint, and my fetlock joint are not desensitized. And if the horse doesn't have feeling at the front of the limb, so at the coffin joint or the pastern joint or the fetlock joint, that's certainly going to change how I interpret the localization of how if the horse looks better and I know that he's desensitized at the front part of the fetlock joint, then as far as localization goes, I have to assume that the lameness could be anywhere from the fetlock distal rather than the traditional palmar digital nerve block, and assuming that just the heel or the caudal third and the sole of the foot is blocked. So it definitely does change how I interpret the localization.
Yeah, and that sort of leads me into my next question, which is, do you have any tips or advice for interpreting the results of local anesthesia? What type of information does this give you about the horse and the lameness, and what type of information does it not give you?
Yeah, certainly, in that particular situation that I just mentioned, that potentially the palmar digital nerve block has been desensitized up to the fetlock joint, I have to determine, that's a much bigger area of localization. So in a case like that, I might need to, before I even do any imaging, I might say, okay, that's just too much real estate for me to try to determine what's going on. And I'll come back the next day or in a day or two, and then start with intra-articular blocks to narrow down my localization before I jump to any diagnostic imaging. So, however, if you did have a horse that blocked all the way up to the fetlock with that PD block, if you took radiographs of the foot, the pastern, and the fetlock, and you saw changes in the radiographs in the foot and the fetlock, that's certainly going to fuzzy up your interpretation. So that's really why I would want to come back and do some more localization to just make sure that if I see something on radiographs in two areas, then I have a better idea of what the actual cause of the lameness might be. In that particular situation, it does help me determine whether I need to do more blocks. It does tell me whether I should, hold off on doing diagnostic imaging or go ahead and do diagnostic imaging. So certainly checking and knowing what your localization really is going to be helpful. And as far as what kind of information it doesn't give us, I think certainly diagnostic anesthesia is very important for localization, but it's not foolproof, and it gives you an idea of an area, but it's certainly not going to tell you exactly what is going on with the horse. They can be sneaky and they try to hide things from you. So I would never rule out that the block has migrated proximally. Maybe they still have skin sensation, but they may be blocked higher up. So if you do your diagnostic anesthesia, you've got a fairly precise localization, you take your radiographs or do your ultrasound and make your initial treatment plan. If the horse is not responding as you would expect based on your localization, based on your diagnostic imaging, then certainly I would come back again and reblock in a different fashion or confirm my localization and confirm my findings on diagnostic imaging. And if I'm still having treatment failures, then potentially it's time for more advanced imaging. I try really hard not to just weigh all of my decision-making on the response to one particular diagnostic anesthesia localization, because I think there's a lot more happening in the horse's body that we don't know.
Yeah, that makes a lot of sense. Do you have anything else you would like to add on the topic of diagnostic anesthesia before we wrap up?
I would say, take-home messages would be to remember that the block is probably always going to migrate more proximal to what you think it is. And the other thing is that really don't be afraid to do some intra-articular anesthesia to really narrow down your diagnostic imaging and what's going on with the horse.
Great. Well, thank you so much, Dr. Kelleher, for joining us. And thank you to our audience for listening. And a very special thank you to our sponsor, Merck Animal Health. If you have any questions or suggestions for the podcast, please send me an email at csisson@equinenetwork.com. That's CSISSON@equinenetwork.com.